Greetings, this is Dr. Doyle and you are viewing Module 4 on distribution of toxicants in the body. In addition to this module, you will find information on this topic in chapters 3 and 5 of your textbook. In Module 2, we learned that the toxic effect of a xenobiotic could be attributed to two factors, the toxicokinetic and the toxicodynamic effect of the xenobiotic. In this and the next several modules, we will focus on toxicokinetics, which you may recall is what the body does to the xenobiotic. Paracelsus had noted that when the dose of a xenobiotic exceeded a certain level, which we will call a threshold, a toxic response may be observed. Many years after this observation, we now know that it is not simply the dose of the xenobiotic to which one is exposed, but, more accurately, the concentration of the xenobiotic that reaches the target of toxic action. Toxicity can be quite variable between different people exposed to the same dose of a xenobiotic, but there is much less variability between individuals having similar concentrations of the ultimate toxic species at the target. The ultimate toxic species can be the parent xenobiotic, or it can be a more toxic metabolite. The concentration of the ultimate toxic species at the target is dependent upon many toxicokinetic factors that we will discuss today. We saw this diagram before when we were talking about the first step of intoxication, which is exposure. After exposure, the xenobiotic enters the body as it is absorbed at the site or sites of exposure, then is distributed through the body, and may interact with tissues based upon the chemical structures of the xenobiotic and molecules in the tissue. Toxicity may result if the xenobiotic or a toxic metabolite reach a critical target that is modified in such a way as to disrupt homeostasis. Alternatively, the unbound parent xenobiotic and/or its metabolites may accumulate in a non-target tissue, which would be called the reservoir, or eliminated from the body by a number of routes, the major one being the urine. Although absorption can occur through the digestive tract, respiratory system, or through the cutaneous route, we will focus on gastrointestinal absorption because this is the most common route of toxic exposure, especially for drug-related toxicity. No matter where absorption is occurring, uptake of the xenobiotic by the body is governed by the same principles. Absorption will occur through paracellular or transcellular mechanisms. Paracellular absorption may occur for small polar molecules but is limited to epithelial surfaces with few tight junctions, such as the epithelial cells lining sinusoidal spaces of the liver, peritubular capillaries of the kidney, or lymphatic vessels. This does not apply to cells exposed to the external environment, such as the mucosal cells of the stomach or intestines, the alveoli of the lungs, or the stratum basale of the epidermis. Therefore, absorption primarily occurs by transcellular mechanisms. One of these mechanisms is passive diffusion of the xenobiotic through the phospholipid bilayer of the epithelial cell membrane. Many toxic xenobiotics are nonpolar, as indicated by a high octanol-water partition coefficient, and easily diffuse as long as a concentration gradient across the membrane exists to drive diffusion. Passive diffusion of nonpolar xenobiotics through cell membranes occur according to Fick's law of diffusion, which states that the flux or movement of xenobiotic across the membrane over a given unit of time is proportional to the products of the permeability of the membrane the area of the permeable membrane, and the concentration difference across the membrane. Organic acids and bases can also be absorbed by passive diffusion if they are in their uncharged, unionized, or ionized states respectively. An example of this would be benzoic acid, which shows the best absorption in the stomach where it is protonated and uncharged. However, benzoic acid absorption is actually greater in the intestine, even though less is absorbed per unit of area, because the small intestine has a much greater surface area than does the stomach. Other polar xenobiotics are absorbed by other transcellular mechanisms, such as facilitated diffusion, active transport, or facilitated transport. The term facilitated means that absorption requires a transmembrane protein which binds the xenobiotic and moves it across the membrane. In the case of facilitated diffusion, this does not require the input of energy, but does require that the xenobiotic is moving from a region of high concentration to a region of low concentration, just like in simple diffusion. Active transport also requires a transmembrane protein, but can move a xenobiotic against its electrochemical gradient. This transport process requires the input of energy from ATP. An example of absorption of a polar xenobiotic via active transport is the divalent metal cadmium. The small intestine has divalent metal transporters for the uptake of iron and calcium. However, cadmium absorption through the digestive tract is rather poor because iron outcompetes cadmium for the same transporter. The story is quite different for cadmium absorption via respiratory exposure, where there is no significant competition by other divalent metals for the transporter. Cigarette smokers can develop significant cadmium blood concentrations because tobacco leaves contain a large amount of this metal. In addition to the presence of the divalent metal transporter on the lung epithelial cells, respiratory absorption of cadmium is high because the alveolar epithelial cells are in very close proximity to the perialveolar capillaries. Xenobiotics that are absorbed by the gastrointestinal mucosal cells then diffuse through the extracellular fluid until they reach the submucosal capillaries in the lamina propria. But some lipophilic xenobiotics may also enter the lacteals within the intestinal villi and first go through the lymphatic system before entering the circulatory system. As previously mentioned, the amount of xenobiotic that is absorbed at the site of exposure is not only dependent upon the concentration of xenobiotic at the absorption site, but also the duration of contact with the absorptive surface, which is called the residence time. So, with regard to oral exposure, rate of gastric emptying and intestinal peristalsis are important factors. After a xenobiotic has been absorbed by the enteric epithelial cell, it must diffuse from the basolateral surface of these cells through the extracellular fluid and then migrate across the submucosal capillary wall by diffusion or by utilizing a transporter protein. Blood from these capillaries drains into the superior or inferior mesenteric vein and from there into the hepatic portal vein. This is an example of a portal vascular system because there is a serial connection of two or more capillary beds to each other, usually by an intervening vein. The distal capillary network is the hepatic sinusoids, which lie between rows of hepatocytes. These sinusoids are lined by highly porous fenestrated endothelial cells, which allow filtration of large molecules into and out of the sinusoids. This enables nonpolar xenobiotics, which are bound to plasma proteins, to enter into the extravascular space, also known as the space of Dissay. At this point, the xenobiotic may dissociate from the carrier protein and enter hepatocytes via the mechanisms that we have discussed. The hepatocytes have a high level of metabolic activity that can result in increasing the polarity of the xenobiotic, thus enhancing its water solubility and elimination through the urine or bile before the xenobiotic has the opportunity to gain entrance to the circulatory system and expose other organs. In some instances, hepatic metabolism results in bioactivation, which means to increase the reactivity of the xenobiotic. This is the reason why the liver is the target of toxic action for many xenobiotics. Once the absorbed xenobiotic has exited the liver via the hepatic vein, it may be rapidly transferred to organs throughout the body by fluid bulk flow in the blood. Polar xenobiotics dissolve into the aqueous blood plasma, but non-polar xenobiotics bind hydrophobic domains of blood plasma proteins. The main plasma protein that serves as a carrier for xenobiotics is albumin, although others such as alpha-1 acidic glycoprotein are important in transporting basic compounds. Transferrin and ceruloplasmin are plasma proteins that are involved in the transport of metals such as iron and copper in the blood. It is important to recognize that although protein binding is essential for transport of nonpolar xenobiotics in the blood, it is only the free unbound xenobiotic that transfers out of the central intravascular compartment. Thus, only the free unbound xenobiotic can be excreted, undergo metabolism, or interact with the target of action. Although the bound xenobiotic is inactive, high protein binding can be dangerous because displacement of the toxic xenobiotic by another ligand can cause significant toxicity. You may well be aware of the bleeding complications that can arise through interactions of other drugs with warfarin, where approximately 99% of the warfarin is bound to albumin in the absence of other drugs that bind albumin. Sometimes toxicity can occur through this mechanism in the absence of a toxic xenobiotic. Treatment of newborns with sulfonamide antibiotics can displace the bilirubin that is normally bound to albumin. The blood-brain barrier in a newborn is not well developed, and the free bilirubin can diffuse into the brain, causing neurotoxicity. The quantity of xenobiotic that will enter the various tissues of the body is dependent upon several factors. First among these would be the amount of blood carrying the xenobiotic that enters the organ. The figure shows the blood flow at rest and the percentage of cardiac output received by various organs of the body. These blood flow rates and the percentage of cardiac output to each organ would change during exercise. The brain and heart values remain relatively constant at rest or during exercise, but these values increase in the skeletal muscle and skin and decrease in the kidneys and abdominal organs and most other organs. In general, we utilize the resting values for the poisoned patient, although this may not be appropriate if there is a high level of sympathetic nervous system activation. We do not necessarily need to consider all organs when discussing the distribution of a xenobiotic in the body. For example, a nonpolar xenobiotic, which rapidly transfers by passive diffusion from the blood to all organs, may be adequately represented by a single body compartment where all organ volumes are added together. A consideration of blood flow to specific organs or body compartments is especially important when constructing the multi-compartmental physiologically based toxicokinetic models, which we will discuss in Module 6. An important organ to consider in such models is the organ or organs which are the site of toxic action. In addition, we must consider blood flow to organs and tissues where there is binding of the xenobiotic, but no overt toxicity is observed. These sites would include fat tissue and melanin granules, which are hydrophobic and will trap nonpolar xenobiotics, and the calcium hydroxyapatite found in bone, which can exchange calcium for toxic divalent metals and phosphate for vanadate. These would be the storage sites, and they are important to consider because they affect the measured level of xenobiotic in sampled blood and also prolong its half-life. The distribution of a xenobiotic from the circulation to an organ can be described as being either perfusion limited or diffusion limited. Perfusion limited, also called flow limited, means that the movement across the cell membrane, which is governed by the permeability area coefficient, is much greater than the blood flow rate. Flow is represented here by the letter Q, which is how physiologists typically express this parameter. An example of perfusion-limited transfer would be the movement of nitrous oxide across the alveolar epithelium into the perialveolar capillary blood. In contrast, diffusion-limited transfer occurs when the rate of diffusion is significantly less than the rate of blood flow, as one would find for the movement of carbon monoxide, which is a more polar gas than nitrous oxide or molecular oxygen. The example shown here is one where the xenobiotic transfer is from the gas atmosphere within the lung to the fluid compartment of the pulmonary circulation. However, the same principles can be applied for transfer between two fluid compartments within the body. It should be apparent that to increase the concentration of a xenobiotic that has a perfusion-limited transfer, the rate of perfusion must be increased. This may occur when regional blood flow to a capillary bed at the site of exposure is increased. I pose to you as a possible topic for a discussion post the following question: is cutaneous absorption of a xenobiotic more likely to be diffusion limited or perfusion limited? And how would exercise affect absorption of the xenobiotic? The figure shows the concentrations of tetrahydrocannabinol, a psychoactive alkaloid found in marijuana, in various organs following exposure. Tetrahydrocannabinol, or THC, has not been established as toxic to humans, but I am using this data because it illustrates the type of body distribution that would be expected for a nonpolar xenobiotic. Important features shown here are that the concentration is initially highest in the blood, and this would be due to the fact that we are looking at experimental data from an animal that received an intravenous injection of THC. The next organ to reach peak THC concentration is the brain, which is a relatively small organ that receives a large amount of cardiac output. Next in order, we see distribution to the highly perfused organs, the less perfused organs, and finally to fat tissue. The triglycerides within the fat tissue provide a storage depot for nonpolar lipophilic xenobiotics, and we would expect the THC concentration in blood to be maintained at a low level for a long period of time beyond 120 hours of administration as the xenobiotic slowly leaches from the fat tissue. This data illustrates an important principle, which is distribution is initially determined by relative organ perfusion and diffusion of the xenobiotic into the organ, and final distribution is determined by the affinity of the organ for the xenobiotic. These organ concentrations can be determined experimentally in animals, and this is often done in toxicology studies. It is especially important to know the concentration within the target organ where toxicity occurs. Toxicologists would like to have human data, but this is seldom possible. However, estimations of the concentrations in different toxicokinetic compartments representing organs, including the target organ, are possible through the use of physiological-based toxicokinetic models. The previous slide showed the distribution of THC following intravenous injection, but the distribution of this xenobiotic may have been quite different if it were administered orally. With oral administration, the xenobiotic would be transported to the liver by the hepatic portal vein following intestinal absorption. In the liver, the xenobiotic may undergo metabolism to generate polar metabolites of THC that can then be eliminated. In this scenario, we might see the peak THC concentration first occurring in the rapidly perfused organs, which would include the liver and kidneys, and a later occurrence of peak concentration in the brain. The observed THC concentrations in all organs at all times may also have been reduced when comparing oral and intravenous dosing, because hepatic metabolism could more rapidly generate metabolites that are excreted in the urine or bile. There are many metabolic pathways in the liver that can either increase or decrease the toxicity of a xenobiotic. Many hepatic enzymes have multiple xenobiotic substrates, and some xenobiotics can be metabolized through more than one pathway. There are basically two sets of metabolic reactions in the liver. The first involves an activation of the xenobiotic, usually an oxidation process. This may be followed by a second process called conjugation that adds a chemical group to the metabolite, which allows the subsequent excretion process. This complex process of xenobiotic biotransformation will be examined in greater detail starting with Module 7. Although the liver is the major organ for metabolizing xenobiotics, and the liver is the first detoxifying organ to receive xenobiotics after oral exposure, other organs contain and utilize metabolic pathways for biotransformation of xenobiotics. The enterocytes lining the intestinal mucosa have many of the same metabolic activities as the liver and can accomplish pre-systemic elimination of xenobiotics before they enter the hepatic portal circulation. This includes secretion of conjugated metabolites into the blood for elimination in the urine and by direct export of the metabolite into the intestinal lumen. Other organs throughout the body are capable of metabolizing xenobiotics, especially when the xenobiotic has bypassed pre-systemic elimination by the liver, such as following exposure through inhalation. The Clara cells lining the pulmonary bronchioles have many detoxifying pathways. Some cells that function as nurse cells to other specialized cells also have high xenobiotic metabolizing activity. Examples are the Sertoli cells of the testes and the astroglia of the central nervous system. Bacteria that inhabit the digestive tract also have some enzymes that can either detoxify or activate a xenobiotic. For example, bacteria have beta-glucuronidase activity, which can cleave the glucuronide conjugate from xenobiotics that have been excreted into bile, allowing toxic metabolites to be reabsorbed in more distal regions of the intestine. The parent xenobiotic and/or its metabolites may be excreted by glomerular filtration or tubular secretion processes that are used for endogenous metabolites. Another similarity to endogenous compounds is the reabsorption of some xenobiotics. Most cases of nephrotoxicity occur by xenobiotic-induced injury to the proximal convoluted tubules because this is where tubular reabsorption and secretion occur. Another reason for the high sensitivity of renal tubular cells and hepatocytes to toxic xenobiotics is that they have high energy requirements for metabolism and active transport. This means that they have a large number of active mitochondria, which are frequent targets of xenobiotic-induced oxidative injury. An example is the reabsorption of cadmium from the proximal convoluted tubule by the divalent metal transporter on the apical surface of the tubular epithelium. The cadmium becomes concentrated because of its affinity for tubular cell proteins, including metallothionein, which is abundant in these cells. This leads to cadmium-induced oxidative stress with mitochondrial dysfunction and loss. Some xenobiotics, especially glucuronide conjugates, are eliminated in the bile instead of the urine. The major determinant as to the elimination pathway is the transport protein that the hepatocytes use to export the metabolite. Some exporters are found exclusively on the sinusoidal face of the hepatocyte and release the metabolite into the hepatic vein for eventual excretion in the urine. Other exporters, like the bile salt export protein, are found only on the canalicular surface of the hepatocyte. Therefore, these metabolites are transported into the bile duct for excretion. This completes Module 4. Please test your comprehension of the material by taking the short quiz in the Module 4 folder.